Today, I'm going to be sharing some insights about polycystic ovarian syndrome and the role of niacin in both the development of this condition and as a therapeutic option for the management of PCOS. Polycystic ovarian syndrome, which is also known as PCOS, is a metabolic endocrine disorder that is prevalent among reproductive aged women around the world. Characteristic symptoms of PCOS are menstrual cycles that are irregular or absent, dysfunctional polycystic ovaries, infertility, and hyperandrogenism, which is an excess in the production of androgens or male hormones. Hyperandrogenism in PCOS is typically seen as acne and hirsutism, which is coarse hair on the face and the body in areas that are typically seen in men, such as the upper lip, the chin, the chest, the abdomen, and the upper back. And in some cases, excess androgens can cause thinning of the hair and hair loss, which is also known as alopecia. And this happens in women, and it appears to be similar to male pattern baldness. PCOS is a complex and multifactorial condition. As such, its origins are not fully understood, and an exact cause of PCOS has yet to be identified. It is thought, though, that a combination of factors that include congenital abnormalities, exposure to environmental toxins, stress, being physically inactive, diet and lifestyle choices that contribute to nutrient deficiencies, inflammation, gut microbiome dysbiosis, insulin resistance, and obesity are the collective stimulus behind PCOS. It should also be noted that the risk of developing PCOS increases in women who are overweight or obese and in those who struggle with insulin resistance. PCOS is a progressive condition that is probably best known as a leading cause of infertility. However, PCOS is also inherently pathogenic on its own and is known to be a precursor to the development of many other comorbidities, including type 2 diabetes, cardiovascular disease, metabolic syndrome, and endometrial cancer. The mechanism of PCOS affects the female hypothalamic pituitary gonadal axis. This is also known as the HPG axis, which works cooperatively with the brain to regulate fertility and reproduction with hormones that influence the development and the functionality of the ovaries. Normally, the female monthly cycle mechanism is set in motion by a steady, even, and controlled pulsating release of gonadotropin-releasing hormone, also known as GnRH, by the hypothalamus. The regulated pulses of GnRH stimulates the anterior pituitary gland to secrete luteinizing hormone, also known as LH, and follicle-stimulating hormone, also known as FSH. These hormones, which are necessary for ovarian follicle development and maturity, are then carried through the bloodstream to the ovary. Upon arrival in the ovary, FSH stimulates the production of estrogen by the theca and granulosa cells of the ovary. This occurs during the follicular phase prior to ovulation. Then, during the luteal phase, LH stimulates ovulation and the subsequent formation of the corpus luteum, which produces progesterone after ovulation occurs. The post-ovulation surge of progesterone is actually key to the proper function of subsequent ovulatory cycles because progesterone has the ability to regulate the pulsation release of GnRH and keep the release frequency steady and even. And we know now how important this is since the frequency of GnRH regulates the ratios of LH and FSH that are secreted. So in a sense, progesterone ensures that those hormones stay consistently in balance with one another and ensures proper signaling and function of these hormones when the menstrual cycle begins again, and of course with each subsequent ovulatory cycle as well. With PCOS, we find hormone imbalances that cause markedly different results. Instead of a complete ovulatory cycle that culminates in either menstruation or pregnancy, with PCOS, follicles do not mature and ovulation does not occur. Without ovulation, there is no corpus luteum and therefore no progesterone synthesis. The PCOS mechanism affects the HPG axis, beginning with an increase in the pulse frequency release of GnRH that becomes erratic, and this is caused by the lack of progesterone. This causes an imbalance of hormone ratios released by the anterior pituitary that results in higher levels of LH and much lower levels of FSH. This is significant because without adequate levels of FSH, the follicle cannot reach maturity with the ability to ovulate. When ovulation fails, the non-functioning follicles remain inside the ovary, accumulating with each incomplete cycle as a collection of cysts around the perimeter of the interior of the ovary, hence the term polycystic. However, this hormone imbalance caused by the lack of progesterone does not end with premature ovarian failure. The increased LH levels stimulate the production of excess androgens, which cannot be converted into estrogen as they would under normal circumstances due to the low levels of FSH. This not only results in the characteristic PCOS symptoms of acne, hirsutism, and alopecia, but it also becomes a trigger for insulin resistance. Insulin resistance adds yet another layer of complexity to PCOS in several ways. Insulin resistance can further contribute to the obstruction of ovulation, as well as promote increased androgen production, which drives weight gain and the accumulation of visceral fat in the abdomen. It also inhibits the synthesis of sex hormone binding globulin by the liver, and this allows excessive androgen production to continue. And all of these reactions, which are induced by insulin resistance, fuel and perpetuate the ongoing vicious cycle of hormone imbalance and anovulation that is PCOS. As mentioned previously, a contributing factor to PCOS is nutritional deficiencies, one of which is deficiency in niacin, or vitamin B3. Researchers have discovered a correlation between niacin insufficiency and increased pulse frequency of GnRH and the subsequent effect that this has on increased LH synthesis, the dysregulation of FSH signaling and ovarian function, and arrested progesterone synthesis. Additionally, niacin deficiency has also been linked to the production of inferior and unproductive oocytes within the follicles. Since there is no cure for PCOS, conventional treatment focuses mainly on pharmacological disease management that uses birth control pills to regulate menstruation and ovulation and prevent endometrial hyperplasia, which is the precursor to endometrial cancer. It also uses metformin to improve insulin sensitivity, ovulatory function, and lipid profiles, as well as steroids to alleviate the symptoms of excess androgens. However, lifestyle and dietary modifications are also considered to be essential for managing PCOS as well. Evidence for nutritional management of PCOS supports adopting a reduced calorie, low glycemic index dietary approach for naturally improving insulin sensitivity, reducing triglycerides and LDL cholesterol, promoting gut microbial diversity, and reducing body fat. Omega-3 fatty acids are also recommended for increasing HDL cholesterol levels and for promoting the synthesis of sex hormone binding globulin. Additionally, supplementation with probiotics and various other vitamins, especially the N1-methylnicotinamide and myo-inositol forms of niacin, is also recommended. Studies have found that N1-methylnicotinamide helps to regulate the pulse frequency of GnRH and alleviate symptoms of hyperandrogenism. Myo-inositol has been shown to improve insulin sensitivity and the integrity of oocytes. It has also been shown to help reinstate regularity of menstrual cycles and ovulation, and even resolve infertility in some women with PCOS. And it's also been found that myo-inositol is an effective natural alternative to metformin. It should be noted that there are no known side effects associated with myo-inositol supplementation. However, niacin dosages that exceed 50 milligrams daily are associated with niacin flushing. This is a temporary harmless burning sensation and reddening of the skin on the face and the chest. And higher intakes of the nicotinamide form of niacin can have other adverse side effects, including nausea, vomiting, and an increased risk of liver toxicity in dosages of 3,000 milligrams per day. An effective alternative to supplementation is dietary niacin, and there are no side effects with the various forms of niacin when they are obtained naturally through foods. High concentrations of myo-inositol can be found in grapefruit, bran flakes, Brussels sprouts, lima beans, peanut butter, navy beans, green beans, peas, and cantaloupe. Likewise, N1-methylnicotinamide can be obtained by consuming eggs, fish, poultry, meat, liver, nuts, seeds, legumes, mushrooms, brown rice, rice bran, and wheat bran. Another way to increase niacin intake is by consuming foods rich in tryptophan. Tryptophan is an amino acid that can be converted into niacin by the liver. Tryptophan can be found in turkey, chicken, fish, egg whites, milk, cheese, peanuts, sunflower seeds, sesame seeds, pumpkin seeds, and soybeans. Hopefully, this information has shed some light on how the mechanism of PCOS affects the HPG axis and the hormonal balance that are critical for normal ovulation and the precise regulation of menstrual cycles. I also hope that this has provided insights for you into the important role of niacin in the development of PCOS and as a means for prevention, and also as an effective natural therapeutic option for treatment, management, and improved outcomes in women with PCOS.